Hello, everyone, and welcome to Vita News Live. I am your host, Dom Garrett, and I am so excited to be able to join you today. We have an amazing panel and a wonderful discussion. We are back after 2 weeks of our, we had a little bit of a summer break, a hiatus. As you can see, we've got a little bit of a new background, and there is no better way to be able to break in this new background and to get back in than launching this brand new series, which we have entitled Why Bans Are Not Best for LMICs. If you happened to see our video that we released last night, we have launched this new series mostly in response to a paper that was put out by a Bloomberg-funded non-governmental organization called The Union, in which they called for the outright ban of all safer nicotine products across low and middle income countries. Now, we know, and many of you watching this know, that many health experts and advocates and health professionals that are on the ground disagree with this type of a position. They also disagree with the idea of trying to lump all LMICs together. You know, there is a wide range, many different aspects to each one of these individual countries. And we wanted to do our part to be able to help lift up those voices, to be able to speak to what the impact of these types of bans and these types of policies can have on the ground. And so we thought no better way to be able to start that than with a panel focused on India. As you may know, India is home to 12% of the world's smoking population. We have discussed it a little bit on our broadcasts up to this point, and I'm very excited to be able to launch this series and launch this panel with a set of 3 absolutely amazing guests. And I am very excited to be able to welcome all of them in for this discussion right now. First, we have Samrat Chowdhery, who is the governing board president of INNCO, the International Network of Nicotine Consumer Organizations. We have Dr. Sree Sucharitha, who is a professor at the Department of Community Medicine at the Tagore Medical College Hospital, as well as Dr. Nimesh Desai, who is a professor of psychology and also is the director of the Institute of Human Behavior and Allied Sciences in Delhi. Thank you so much, all 3 of you, for joining us on our panel today.
Thanks.
Thank you.
Great to be here. Can I just clarify that I'm a medical psychiatrist? No?
Wonderful. Wonderful. So what I would love to do then, I guess, off the top, just to give each of you an opportunity to sort of introduce yourselves and how you sort of fit into this puzzle. Dr. Desai, if we can just start with you. That would be
Okay. All right. Like I said, I'm a medically trained psychiatrist for now nearly 40 years. And I spent my time in public academic career, last 20 years of them at a mental health and neuroscience institution that's in Delhi. And my interest in alcohol and drug abuse treatment as a broad field, substance abuse treatment and prevention, goes back to late 80s and early 90s. And what I began to realize in the 90s itself is that focus on helping people quit or do something about their tobacco habit was kind of falling between 2 stools. The substance abuse treatment services did not then and still do not mostly consider helping people quit or do something about tobacco as an important priority at all, nor do the routine mental health services. And so way back in 2001, we were the first to start a tobacco cessation clinic in India. And then in 2002, the WHO country office and the National Ministry of Health came up with a network of 12 centers across oncology, mental health, and the specialties that's now gone up to many, many more centers. I'll come to data that emerged from that network in the next few discussion points. But my adherence and conviction to harm reduction comes from that experience in trying to help people quit completely, 1. And 2, parallel experiences in substance use treatment, specifically opioid treatment. How harm reduction approach in opioid treatment and the other substance use prevention and treatment is actually worked out much better than the abstinence-oriented goals. I'll stop there for now. So,
Yes, I'm, very, as I was looking through your personal history and just hearing, in the conversations that I had with Sree and Samrat, I'm so glad to be able to hear more about your experience just with harm reduction in general and how that pulls together. But before we get that, I would love to hear, Samrat, if you can just give our audience, obviously you've been on our program before. Thank you so much for coming back. If you could just, give our audience today a little bit of a background into your role inside of tobacco harm reduction, and if you can also just a little bit sort of fill us in on sort of how you see some of these different policies. What does India look like right now because of some of the policies that have been implemented?
So my personal journey started when I tried to quit smoking, a long habit, and I tried everything that I was told, right from gums, patches. I took medicines, local remedies, none of which worked until I found a colleague. I was working at a newspaper at the time, and a colleague was vaping, and I could try it from him. And I was astounded that the transition was so smooth. I could, and for me, that was, the Eureka moment, and I really thought that others should have the opportunity to. Then we started having bans in India. Small states started banning, and we thought we should push back against it in some way, which is when we formed a consumer organization focused on vaping, and since then also on other PHR alternatives. What we thought initially was that this is going to be easy. It's easy to see that these are much less harmful. And in a country like India, their use would be tremendous because we don't have cessation centers, we don't have access to cessation support, which is not wide enough, especially in the rural areas. So this would be a good solution that the government would adopt. Of course, little did we know that there are a lot of other big forces which are pushing back against these policies, and that's how I got more and more involved to a point where we had a ban late last year, and we're still fighting it.
Thank you so much. And Sree, I would like for you to give an introduction, but before you do, I just want to let everyone that is watching this know that, very much the reason why we are having this discussion right now is because of the passion that Sree actually had for this individual topic. There's multiple email groups and different listservs where, a lot of the type of harm reduction advocates and researchers are talking, and Sree was really who's the person that spearheaded this effort, understanding that having this idea of, honestly, this philanthropic colonialism that we are seeing when we have these organizations coming down from on high, trying to tell people how they should do their research or what they should or should not do. Sree was very vocal, saying that this was not something that should happen, and really passionate about being able to help lift up these voices. And I personally consider myself lucky to have the opportunity to just speak with you one-on-one. And I am so glad that we have this opportunity to be able to bring more voices together on this forum. So Sree, if you could just sort of give everybody a little bit of a background as to why you were so passionate about that, and how some of these bans have actually impacted your work as well.
Yeah, thank you, Dom. Thank you for inviting me on this forum of yours, Rendezvous. And this is my first foray into this live streaming area. And I thank Samrat Chowdhery for actually enabling me to be here today. I contacted him last year as part of my research into tobacco harm reduction. I was doing this research into electronic nicotine delivery system users in India, and I wanted to reach out to him because he's the director of Association of Vapers India Forum. It's a consumer advocacy body, and I wanted him to help me to reach out to electronic nicotine delivery system users in India, otherwise vapers in India. I reached out to him and asked him to support me to gather data from them. That's where our association started, and he mentored me and he supported me. And today, whatever I am is because of his support and handholding. And I am a researcher I'm a medical doctor, and I'm a public health specialist. And right now I'm a professor in a private medical college. Research has been my passion for a long time. I'm almost 15 years into research. I have researched various topics, and tobacco harm reduction is something I entered accidentally, but I could identify because of my background in HIV and AIDS. I did my fellowship in HIV and AIDS, and I also have done a course in Asia Harm Reduction and Drug Policy, which is funded by Open Society Foundation. So I have a good background in harm reduction as such. But coming to tobacco harm reduction, the union in 2013, I was given a scholarship by the union, and where I have done my multi-drug resistant tuberculosis project. But this time in 2019, when I submitted my abstract for a World Lung Conference, it was not accepted. And when I went and attended the conference in Hyderabad, all the abstracts which were selected and presented in the conference, they looked very partisan. The partial selection of the scientific abstract itself showed me the union has been hijacked. And the way the science is being promoted, the one-sided version of science promotion, the one-sided selection of topics, it itself showed that there is a division of science and there is one-sided presentation of science, which is harmful for science as such. So the scientific promotion of science by certain parties, the scientific way of promoting certain science, that is something which is not going well with me. And suddenly this webinar, which is promoted by the union, saying that bans are ideal for LMIC, it actually touched me in such a way that I became like, what is happening again? This colonial shades, it triggered in me something which helped me to understand like something is happening again and again in a country like India. Philanthropists coming, funding indirectly from outside the country and driving the health policy and dictating us what kind of science we have to practice, what kind of research we have to undertake, what kind of policy has to be made in a country by external drivers. That is something which actually triggered me to think like, what should we do in a country which is facing a lot of health inequalities. One side we are troubled with communicable diseases, one side we are troubled with non-communicable diseases, in between we are troubled with health inequalities driven by external actors. That is where I started to think like, we have to talk about it, at least we have to raise our voices. That is where I wanted to discuss this with experts, and I wanted to start that conversation with my limited expertise. That is where I wanted to have this discussion, and I thank you for creating this platform and inviting experts like Dr. Desai, and consumer advocate and kind of crusader in the country for tobacco harm reduction like Samrat Chowdhery. Though he doesn't like me to admit it, he's my mentor. I wanted them to talk about it and raise the voice in their international forums where they frequently have the platform. They have to talk about it, because there are limited people who has the stature and expertise and image who can carry this message to the right corners and right areas where people will listen to them, and they have to listen. That is my sincere request.
Wonderful. Thank you so much for sharing that. And again, just thank you so much for really having that passion and that drive to want to be able to lift these voices up. And so in that line that you were discussing there, I would like to ask Dr. Desai. You obviously have a wide breadth, years, decades of work inside of the public health space, inside of the harm reduction space. As you see these position papers come out, for instance, from the union, calling for just a ban on these types of products, is this something? Is this surprising to you to see a position taken like this when there are products that can help in harm reduction? What were your initial thoughts when you saw this paper?
Yes, it is, and there's possibly two or three strands of thought and ideas that I'll put together. One is, as you and Sree said, let's face it, with no implication for our colleagues now who are with us. There's certainly been, as you said, Dom, the lasting vestigial remains of the colonial imperial mindset. Uh, as much as that the first or the second world seems to decide what's good for us and what's good for them. That's the first reservation that I have, and I'm completely with Sree on that. Today or later, maybe we'll talk about that more. But the second set of thought that I have is, like I was saying earlier, late 80s to early and mid 90s, even in substance abuse treatment, I kept coming across this experience of almost hitting your head against the wall when you have a single point agenda as a treating team or as a public health policy. You say you're going to try and help everybody achieve abstinence. It just didn't seem to work. And I learned it around that time that the science even intentionally was beginning to realize that the least that you could do in alcohol treatment for sure was what's called mirror image outcome studies. So that if you are treating 500 or 5,000 people with alcohol dependence, you try and see how many of them remain dry or wet for what length of time, 2 years or 5 years as a mean, rather than looking for abstinence all through. That abstinence doesn't work well has been fairly well established, and the story in opioid substitution is a large one in itself. But my experiences come from there. And the third major issue that I have learned, that I got trained in public health as part of the Fulbright Fellowship, and I guess my own evolutionary learning is indeed we would in the LMICs want to pick up the principles that the first world or the Western world talks about healthcare practice, about medical practice. And the one overriding principle, if I haven't got it right, is to offer a variety of options. Not let the system or a clinician or a clinical team decide what's good for the patient or the client. This is true for a lot of medicine by now. This is true for a lot of psychiatric practice. I think it should be true for all that we are talking about. Indeed, if I may briefly say, uh, the much talked about evidence-based medicine or evidence-based practice amongst its four tenets has a very important tenet number 3 of collaborative decision making between the provider and the consumer. And so the least I would want all of us across the globe is to accept that fundamentally principle of offering a variety of choices and then making a collaborative decision between the provider and the consumer. That's the consumer empowerment that a system, or a nation, or a line of thought must offer. And about that, I'm with every passing year getting more and more convinced. Uh, to me, it seems Samrat and Sree and all of us that we need to plug for that fundamental idea, the right of the consumer to have a set of choices from which he or she can decide on his or her own, or in consultation with the provider.
Exactly. And Samrat, perhaps you can speak a little bit to that from the consumer angle. Obviously you have used these products yourself to help you quit smoking, but in your role with INNCO, you are in contact with hundreds, thousands, tens of thousands probably of consumers around the world. Would you say that really is a rallying cry, for consumers in India and in other LMICs, that they just want to have the option to have the choice?
Sure, I think that is the central point. What we are asking for is that, yes, give us a choice. And I think people are responsible. It is not that smokers do not know the ill effects of smoking, but it's also a fact that a lot of them try really hard but cannot quit. So they're looking for support. And what we should be doing is increasing the number of quit pathways for them, because not everyone is smoking in the same way. They are not relating to smoking in the same way. They didn't start smoking for the same reasons. Some of them may not even want to quit the dependence. So what would be ideal is to give them options. Okay, if this works for you, you should try this, because the goal is to reduce the number of deaths or the death and disease tobacco is causing. If we make it a moral issue, then we are sidetracking ourselves, because then we are talking about this is what you should or should not do. But that we know, and Dr. Desai would be the best guy. He could tell you that didn't work in the drug war. And so there's little scope that will work in this new nicotine war. What other problem that we face as consumers is that despite being 1 billion people who smoke, or over a billion people who smoke, and if 80% of smokers or tobacco users live in LMICs, that is a population of 800 million. They don't have a voice. They don't have a platform. They are not spoken to. The way this tobacco war has been designed, that is that consumers are excluded from decision making, and these are the decisions which affect us for life and death. And yet we have no say in these policies. If we speak against these policies, the first thing that they do is, brand us as tobacco industry. Anyone who speaks against these policies is tobacco industry.
Yes,
When
unfortunately.
you draw consumers into that, when 1 billion people get disenfranchised because of the way you frame that war, then that's that's really sad and something to fight against. Which is what we are doing at INNCO, is to create a platform for consumers to have a say in these policies.
Yes, please, Dr. Desai.
Can I also strike a slightly different chord? Although we are very much on the same frequency about the basic idea. When you ask Samrat, and when Samrat says that yes, consumers are looking for choices, I guess, Samrat, that would be restricted to the kind of advocacy groups that you have brought forth, and the kind of clients that you deal with. If I might ask you and all of us to consider the broad spectrum of clientele across the country, across classes, social classes that India deals with, the consumers even being aware that he or she should have a choice is not an idea that's mostly on their radar, right? Culturally, and in terms of the system, consumers of any system, and certainly healthcare system, uh, are largely in the mindset of saying, I will go and ask the doctor, what do you think is best for me? Indeed, if I might elaborate my own experience, and I've checked this with a lot of colleagues across the country in psychiatry, in medicine. Even if there have been clinicians or clinical teams in the late 90s or early part of this century in this country who were to try collaborative decision making, the individual person, or as is often accompanied by the family, they would actually say, Doc, I don't know enough. You tell me what is best for me. And so that basic fundamental mindset is something that, Samrat, I want to say to you, we need to really broaden the base of those consumers who should be looking for choices. Do I make sense?
Makes tremendous sense, and a lot of work needs to be done on that. Because we've become sidetracked into banning these devices, where I think the focus should be on letting people know about the harm reduction. Because if a smoker goes to a shop and sees one cigarette product and sees a harm reduced product, and if he knew that it was a harm reduced product, we can rely on people to make safer choices. And I think this is where it has gone wrong, where some people believe that people are not capable of making safer choices. And I don't think that's true, because people are making safer choices at every step of their lives. And once they know that it works and it's an effective way to quit or move out of, let's say, smoking, or even smoke harmful smokeless tobacco use, at least we have a better chance of them taking that route. But if you're going to ban them, then you're just taking those choices away from them.
I certainly don't want to monopolize this, but allow me this intervention. Uh, to a great extent, Samrat and Sree, you understand this on your own, or when I remind ourselves. But to a great extent, that's the socio-cultural fundamental mental set. As I often said in a variety of settings, not only in last part, I mean the previous century, but even in this century, in Indian families, let's say uncle or an aunt was visiting from out of town, and the uncle were to decide to take the 5 kids of a family or 7 kids to the ice cream parlor. Traditionally, the kids are not asked what flavor of ice cream would each one of them want to order. It's the uncle who is buying the ice cream who will decide everybody will have chocolate. That's great. Right? So inherently, what Samrat, you and I are talking about, although it's different for the newer generations, traditionally, socio-culturally, that element of keeping oneself informed of the choices, step one, two, exercising that option, and three, expressing, if not asserting, that right to make a choice, is inherently a bit low. And so, like you said, we really need to do a lot of work for that.
Sure, I think a lot needs to be done there to communicate first accurately what is the risk reduction. I think a lot of tobacco users are not even aware, I mean, in India, that it is possible to reduce risk from tobacco use. Because the line that is being rolled out all the time is that tobacco in any form is bad. But that is not accurate, as we know from the evidence that's available to us. So I think a bunch of it is the way communication has happened so far. And a lot of course correction can happen on that front if we really decide that, yes, this is going to help save a lot of lives.
This is a marvelous discussion. I'm so glad that we are having this. This is good. I do want to just reiterate to everybody that is watching, if you do have any questions for our panelists, please make sure to drop those in the comment. We will make sure to get to as many of those as possible. Sree, I did want to ask you a question in particular. I know that Dr. Desai talked about this idea of collaborative learning and collaborative work when it comes to how we are talking about these issues, how we're talking about it with researchers and scientists and doctors. And I know that in our email conversation, one of the things that you said, you think that it's very important for LMICs to be able to work together, to be able to take more of an active role in the leadership of how these policies are set into place in these countries. Obviously, the discussion we're talking here, the cultural aspect of how each country works is different. And I think that is very important for steps forward. So could you perhaps speak a little bit to how you've seen some of that collaboration work, especially in the work that you've done in HIV and AIDS research, and how you can sort of see a path forward specifically as we're talking about tobacco harm reduction in India?
Yes. As we discussed earlier also in our email groups and otherwise, LMIC, low and middle income countries, is a huge chunk. And there are so many diverse socio-cultural influences and regional factors which influence the tobacco harm reduction policy making. And as part of certain scholarship related work, I'm seeing certain countries like Malawi doing exceptionally good work. And I'm aware for the past 1 year, such work is not being done in India. When I look at Malawi doing tobacco harm reduction related work, raising awareness and doing very creative work related to tobacco harm reduction, and I am doing tobacco harm reduction work, and there is no such work being done in India. So India is a huge country compared to Malawi. And when we compare the tobacco harm reduction landscape in Malawi and India, we are non-comparable. So when you talk about low and middle income countries, we are not the same. And similarly, take for example, Pakistan. I know some scholars are doing good work in tobacco harm reduction in Pakistan when it comes to smokeless tobacco work, snus, which is a safer alternative. They are trying to make a locally equivalent product for Swedish snus. And we know from Samrat's work, he's trying to work out an alternative Swedish snus product in India. So because we are working in tobacco harm reduction, we know certain similar individuals and individual teams doing tobacco harm reduction work in India. But otherwise, there is no broad network of tobacco harm reduction individuals or networks or groups working as a collective in India. So unless we form a collective for low and middle income countries and form a tobacco harm reduction alliance for tobacco harm reduction collective work in low and middle income countries, and we form a separate chapter and we have our own vision and goals and kind of 5-year plans, we don't know what other people are doing. Unless we have our own chapter and we have our own vision, we don't know where we are going, where we are leading, and we don't know who else is making plans for us. So we need to come together and we need to have our own chapter. We need to have our own individual plans for at least for the next 5 years to counter activities like Union is trying to do for us. And so it is imperative, like what you are doing for us for India, whatever you are planning to do with other LMIC countries, you have to put up a collective platform for us. Maybe it is too much for you, but we request you to bring us all together, okay, and try to bring us all
Okay.
together. And, yeah,
Yes, Dom.
bring us
You
all
must now.
together. Bring us all together and put us together so that we will try to be together and we will work out between ourselves and we will make a pathway for ourselves, and we have to come up with our own leadership. Otherwise, I'm telling you, this high income countries, I'm seeing their leadership. When someone puts up a mail, all of them come together, but I'm not seeing that for us in the low and middle income countries. I write a mail, maybe Samrat talks to me in that group, but no one else comes and responds to me. I feel like a loner in that nicotine group. So that is the reality. So we have to come together as a low and middle income group collective. Roberto comes together with me, Andrew responds to me, Atakan responds to me in that group, Michelle responds to me. So 5-6 people are responding to me. So I don't feel like a loner, but from India, except Samrat, no one responds to me. I feel like a loner, to be honest. So it is important that we all band together. We all have to come together. We all have to have a flag called LMIC, and we have to be together. If we have to move forward together as LMIC chapter, and that is my vision. Please put us together. And I don't know much Malawi, Pakistan, because I'm in that scholarship group. I know they are doing very good work. I'm impressed by my Malawi friend. He's doing very creative work, and I was so impressed. So we have to do something like that. So that is a limited response. That is as much as they know. That's what I can offer. Thank you.
Sure, if I can say something here. So
Please do, Samrat.
One is what I would like to say is that the issues are connected. For example, if you look at the TPD, we may think that it's a European issue, but it has a lot of implications everywhere else. China, for example, when last year it put forward its e-cigarette policy, it was a complete lift-off of the TPD with some modifications. So what I feel is that it's a connected global THR space. Having said that, of course, I do also understand that the issues in LMICs are different. Because even look at the WHO's, the way it looks at THR, or Union now. They're proposing separate policies. I mean, the WHO's Euro wing, the Euro arm, in fact, put out a paper where they said, okay, there is really strong evidence that these are significantly risk-reduced. Whereas the WHO CRO, the Southeast Asian Region Hub, or the Latin American Hub, they are really prohibitionists. So even WHO is seeing the Western issues and the LMIC issues separately. And final nail in the coffin is, of course, the union, which is going ahead and in today's world proposing something so discriminatory. It's on the face discriminatory, saying that people in the West, who of course have access to better healthcare and are better equipped to deal with the consequences of tobacco use, they can have options to reduce harm from tobacco use. But people in developing nations, where access to healthcare is limited, where people struggle if they have a cancer or any disease, those people who need prevention the most should not have access to any means to reduce harm. So, I agree with you, Sree, that yes, the LMIC issues are different, but also they are connected in a little way, and then we have to find a way that this can work together with focus on LMIC issues. And I think it's high time that they were spoken about in a more constructive, organized, and collaborative way.
Yeah, and I mean, I would completely agree with what both of you have said. I mean, we saw we saw that the power of a large group of people coming together for instance, what happened recently in Australia and the potential ban that was put out there. And yes, there was Australians that were speaking out, but then you also had people from all around the world that were actually sharing their stories and being able to reach out and do that. And when you really do think about it, that's part of the reason why I am very glad that, Dr. Desai, that you wanted to come onto the program and that you are starting to show an interest yourself in tobacco harm reduction. Because if you zoom out even further from the idea of THR, which in itself can be fairly niche, even if we're counting everybody around the world, when you look at the larger harm reduction community and how we're not, people are not reinventing the wheel here. This idea of reducing harm instead of just trying to get people to go directly towards abstinence is not necessarily a new idea. And Dr. Desai, I would love if you can speak a little bit to your experience when you see this idea of, of high-income countries versus LMICs. Is that something that you noticed also happened in other harm reduction fights in the past?
Oh yes, oh yes. Scientists as well as the policymakers in this country and this part of the world took number of years to even accept prima facie the idea of substitution for opioid treatment. Of course, there was this whole issue of methadone not being all right. Fortunately, methadone was substituted by buprenorphine, and so buprenorphine is where some of our teams had actually begun the work initially. But there was that geopolitical differential in acceptance of the lesser goals, so to say. And let me bring in what Samrat and Sree and we have discussed more than a couple of times in different platforms. The other trouble with this, one of the issues with this culture is also the inability to accept pragmatism. Idealism and extremism reigns supreme. And so even if you fall flat 5 times on your face trying to achieve the impossible, you must get up and try and do that the 6th time. It's partly religious, partly cultural, So that central issue of idealism versus pragmatism also needs to be brought in alongside what Samrat and I were saying. Large number of consumers need to know that there are choices available. One is information to them. 2, that the abstinence or the total benefit is not the only possible goal. You need to perhaps be pragmatic. And 3rd, being able to say, you know what, doc, I would want this. But something else occurs to me as you were all saying what you were saying. In management terms, what's happened till now, often enough, is a top-down approach. From the West to this part of the world, from the governments and the policy makers to the treating teams, and from the treating teams to the consumers. I think, Samrat, we need to really turn the table upside down, not very drastically, and can't happen, but slowly but definitively, we need to turn that table upside down. There needs to be a correct mix of top-down and bottom-up approach for every level of decision making. I mean, I already spoken enough about collaborative decision making in a clinic setting, but the same will hold between the clinical teams and the scientists and the policymakers, and the same would hold between Afro-Asian countries and the rest of the world. So that's one part. The second thing that I want to do, maybe expand the discussion a little about what Sree was saying, and that struck me about the Hyderabad experience that she had, and in general. Again, one more time to use that concept, the fundamental idea of science ought to be having an open mind, not have a prefixed agenda. And that's why in research terms, we begin every exercise with a null hypothesis, right? The very fundamental idea of a null hypothesis is because a scientific approach or a research design will have to begin with a zero position, keeping its mind open about all. If for a policy or for a clinical team, if it's going to be a pre-decided agenda that this is the solution that I want for you, that doesn't seem science. Like I think Samrat or one of you was saying, that still seems to reek of moralistic philosophical approach. So when you mix the idealism versus pragmatism dichotomy and the genuine need for science, including helping scientists to be open-minded and not with one prefix agenda, frankly, to my mind, it's unthinkable how and why any harm reduction approach is so difficult to get across.
Yes, exactly. So as we are sort of discussing what we're having here, I would really like, I think we've touched on a lot of the different points that we have with some of the issues behind some of the points that the union has specifically made. However, I would like to, Dr. Desai, you alluded to it a little bit of how we can have a little bit more of this conversation about this idea of the colonialist mindset and how that sort of comes in. Do you think that you could speak a little bit more to that, especially how it sort of fits in regards to harm reduction in general or science in that when it comes to India?
Oh, sure. Oh, sure. Frankly, like Sree described her experience at Hyderabad, I mean, with the, again, fullest respect for my previous generations and my contemporaries, without naming the names, but in international organizations, those scientists from India or South Asia are more likely to go places if you actually say, yes, we need guidance, and so we are going to be guided by what that organization or the first world or the second world says. Approaches like Sree, in our generation at least, didn't work too well, and so like I'm very fond of saying, I'm not a UN or WHO guy primarily. I can't be, because like Sree, I will want to have my say and listen to 5 other viewpoints. So that's certainly true. But there's also something else that I should like to have a print of this document from the union, and amongst every other point that they make in those 10 points. See, I find this very interesting and reminiscent. And fourth, argument 5 is enforcement loopholes will be exploited. So the point we seem to be making is that if we can't fix a system, we accept a rigid single solution. I mean, if we can't fix our socio-political economic issue of corruption and how consistent enforcement is difficult, admittedly, the same arguments used to be put up for opioid substitution. The other thing is novel products being a distraction. That really smacks of the imperial mindset that we are talking about,
Yeah.
That you natives, you won't be able to appreciate the differences across various options. And so like a child, you are likely to get distracted by novel approaches. I think like Samrat and we are saying, all three of us, and I've said this too many places that I've said this. We as health professionals, and certainly health professionals in this part of the world, need to begin to develop much more deep-rooted, genuine respect for our clients. That the general population or the clients or consumers that we work with, and that phrase of work with itself is very unusual for India, I must tell you. You don't work with a consumer, you don't work with a client. You prescribe something to the guy. That idea needs to be broken, really. Like I was saying earlier, the newer generations are beginning to do that, but it's still not good enough. And this is the other argument. Novel products will divert resources from tobacco control. I don't really see the strength of that argument. In science,
if I can make a small point there, Dr. Desai.
Please.
This whole idea that will divert from tobacco control. I mean, let's look at the goal of tobacco control, which is to decrease the 1.3 million deaths in India every year from tobacco use. That is the goal of tobacco control, right? And anything that helps in doing that should be the role of tobacco control. I don't see how that diverts. Now, what are the resources that tobacco control has, or what is it that the tobacco control is doing to reduce these deaths? At the moment, it's taxation, So, and then what you're talking about in low middle income countries is taxing the really poor more, so that you can dissuade them. But this is, as you would know, is addiction. It's not a choice. It's not that a consumer or a smoker or a tobacco user is waking up every morning and making a decision whether or not to use a tobacco product. It's addiction. And if you're going to raise prices on it, you are going to hurt them economically. So that's pretty much in the kitty, because what's not in the kitty is cessation services. What's not in the kitty is giving out subsidized or free NRTs even. So it's not that tobacco control is doing a lot. And if there were consumer products where you gave the consumer the choice to do it himself or herself, what would be wrong in that? Sorry, I mean, I just wanted
Well,
to...
no. Do I understand right? And would we be correct in saying that we would like to see tobacco control as a broad umbrella of many strategies rather than one strategy?
Yeah, because right now the strategy is let's eliminate tobacco use. And as you correctly pointed out, that's a very idealistic approach to achieve a perfect world, but we all know that that's not going to happen. Even at the current rate of decline in India, it would be decades before tobacco use is eliminated. So and there are 1.3 million people dying every year. So your way is let's let people die till we achieve that fantastical goal of eliminating tobacco use. Or should we give people access to lower risk alternatives today, which will have immediate impact, positive impact?
That prompts me to put forth an idea that I've had for the last couple of hours this evening as I was thinking about this conversation. Is it time to suggest and start doing a relook at the FCTC?
I think that's well said.
Yeah,
Yes.
because that framework convention for tobacco control was done some years ago. The ideas have changed, and so maybe as a small group or a larger group or as a larger interaction process, at least examine and look at FCTC again.
That is very well said, Dr. Desai. And there's very solid grounds for doing that, because FCTC was signed and ratified in 2003, when there were no novel products, or there was the concept of tobacco harm reduction was not. I mean, it may have been there in theory, but there were no products, which were really significantly risk reduced, barring snus. But now the landscape has changed, so why not reimagine the treaty?
And I happen to have known some of the processes that time. Remember, our good friend Srinath Reddy was the fulcrum around the FCTC, even globally. And Srinath and I have been colleagues, and so we understand each other somewhat, even if we don't often agree. But so going from their individual perspective to, as you said, 17 years is a long time to have the document as Bible.
Yeah, and when so much, the entire landscape has changed.
Yeah,
but
and
their response is let's ban everything that came after.
Yeah, it's interesting to talk about that too, because we saw and we reported on it a couple of weeks ago. The FDA, offered a specific heat not burn product out of the U.S. to be able to be marketed as a reduced exposure claim. However, even though that was said, because of the FCTC, the WHO came out and reminded, just a little strong arm, but reminded countries that this is still considered the same underneath there, even though there has been research and millions of dollars and plenty of hours spent to be able to have that claim. Because of this specific FCTC, they're saying, well, we'll still remember that counts as this, so don't even pay attention to that. I mean, that does seem like you're just sort of spitting in the face of science of this research that's being done.
Yes, it can't be carved in stone, can it?
Yeah.
Sure, and it's more an ideological stance, and that's how sad the situation is when we are looking at the problem from ideological perspective, from the perspective of let's eliminate tobacco use, when we all know, everyone who's proposing that let's eliminate tobacco use knows that it's not possible.
Yes.
Yeah, maximum good for largest number of people
Making things
can happen only if you have a variety of approaches. But really, it would seem that for our conversation here or in other platforms, might be a good idea to slightly concretely start pushing the idea of review of FCTC.
So,
Yeah.
yes. I do want to be mindful of everyone's time. This has been a absolutely wonderful conversation. I am sure it is not the last conversation that we will have here. And I do just want to take time right now to thank each of our guests for joining us. And if you have any additional questions for them, please just make sure to send it to us at FIDA News, and I will make sure to we will make sure to do some follow-ups with all of our guests today. So thank you so much, all of you, for joining us.
Thank you,
Dom.
All right, that is all we have for our broadcast today. As I mentioned before, this is the first in our series, Why Bans Are Not Best for LMICs. In the coming weeks, we will have panel discussions featuring advocates and health professionals and public health experts from Central and South America, from Southeast Asia, from Africa. As you can see, we had many conversations here, so we will have follow-up video content speaking exactly about the FCTC and perhaps ways that we might be able to change that. We will discuss this idea of philanthropic colonialism from a global perspective. Sree will also be joining us again to discuss, women's rights in that fight for tobacco harm reduction with some of the work that she has been doing, and much, much more. If you have any thoughts on any of that, please do not hesitate to reach out to us. You can find us at vida.news on all the social platforms. You can tag me directly at Dom Garrett on Twitter, and we will make sure to get to all of that. As always, thank you so much, and I look forward to seeing you again soon.